myocarditis, myocardial infarction. It can affect kidneys, so nephrologists are getting involved, cardiologists are getting involved, and of course, the general internist, hospitalist, ER physicians, and disaster management experts. So we have a collection of really very learned and experts in their field physicians who have joined this group, and it's growing, this group of experts. And so we will present different dimensions to this disease in each night for 1 hour. And it is really interactive. So it gives me a great pleasure to introduce our first speaker. Like I said, infectious disease is the real expert of these viruses and epidemiology and presentation of this disease. So please welcome Dr. Sajid Choudhary, who is the infectious disease specialist, and he's the clinical assistant professor in UCF College of Medicine, Orlando. He's the chair of Department of Medicine in Osceola Regional Medical Center, Kissimmee, Florida, chair of APPNA COVID-19 Task Force, and past president of APPNA in 2017. He is the graduate of Lamegwal Medical College in 1985, and he will be talking about, I would say, a brief presentation, no formal presentation, but just, I would say, 10 to 15 minutes about the clinical presentation and management of COVID-19, the current trends. So welcome, Dr. Sajid. Assalamu alaikum. You can start. And I think after we can, if everybody agrees, we can even talk in Urdu at some point if we feel like, and people can ask in both English and Urdu. But let's start with Dr. Sajid.
Assalamu alaikum, Dr. Shahid Rafiq. Thank you very much for the nice introduction. As we all aware about this corona pandemic that started in December from China and spreads like exponentially into pandemic over the 3-month period. We have, for the clinical pictures of this disease, we have learned from the cases from China, European like Italy, Spain, and now we are in the midst of this pandemic in USA. So we are learning firsthand by dealing with these patients. I will not go into the common presentations. You all know this, the most common presentation will be 80 to 90% of the people will be like a mild flu-like symptom, like low-grade fever, body aches, tiredness, fatigue, dry cough, and all the symptoms will resolve spontaneously. I will go up to like a moderately symptomatic patients. They will go into the more severe cough and start having shortness of breath. And eventually they will be hypoxic, requiring supplemental oxygen. Most of the time with the nasal cannula, or 1 to 2, 3 liter should be fine. And they stay in that stage and then recover from there. Maybe less than 5% of the patients, they will go into moderate to severe symptomatic disease, and they will go into towards intubation, and then of course ARDS. As a clinician, we come across mostly the patients in the mild to moderately symptomatic patients. And we, until first week when we started seeing patient, that was the first week of March that we started seeing patient in Central Florida. At that time, we did not have any definitive treatment. We had a few studies, limited patient studies from China and Europe, where they had used one of the antimalarial drugs, which is pretty common now, and authorized by FDA for the treatment of COVID-19 disease yesterday, without any proper randomized controlled trial with the hope that it might have limited benefit, but benefit may exceed the potential risk of this medicine. Other medications that have been used, Calitra, which is one of the antiretroviral drug, and we have been using in USA is the remdesivir. By the second week, I personally have started using hydroxychloroquine with azithromycin. I can share you with my personal experience. We have been monitoring the patients with inflammatory markers, which is most sensitive is the highly sensitive C-reactive protein, CRP, ferritin. They are the two most inflammatory markers. They go with the severity of the disease. Other markers, of course, we want to make sure it's not a bacterial infection. Procalcitonin level, most of those patients is a 0, less than 0.05. And we also check the LDH and total CK, because some of the patients, they go into acute rhabdomyolysis, though not like a severe, but the total CK is moderately increased, few hundred to few thousand in some patients. So some of the patients that I have seen atypical presentation, patients are with the syncopal episode, patient without any having fever, no shortness of breath, no cough, just syncopal episode. And in our hospital, there's a low threshold for testing any atypical presentation. They tested for COVID-19 and patient was positive. So we don't know that the cause of the syncope is COVID-19, or he just had a syncopal episode due to cardiac arrhythmia, and then found tested as just asymptomatic carrier of the disease. Same way, there's a few patients that I would like to share. It's interesting that we're seeing a typical presentation of the COVID-19 disease. No significant past medical history, acute onset of shortness of dry cough, fever, body aches, weakness. All the inflammatory markers are elevated, like procalcitonin level is 0, CRP is in few hundreds, ferritin above 1,000, chest X-ray, bilateral interstitial infiltrate, CAT scan, typical ground glass appearance, multifocal infiltrate, but the COVID-19 PCR, SARS coronavirus PCR negative. I had kept that patient on isolation. I had tested that patient 3 times, all 3 times PCR negative. Still patient is on isolation, and today patients start having a deterioration of the respiratory status. Right now, patient is on high flow nasal cannula, still maintaining oxygenation. And then I started him on hydroxychloroquine without even having the positive test, because there's no other reason for this patient to have this clinical picture. There are a few case reports from China where infected patients, they were negative for nasopharyngeal PCR, and subsequently they got intubated, and the deep respiratory specimen were positive for the SARS coronavirus 2 PCR. And this is my second patient, like with this picture. So take home message from for me is, if you have a strong clinical suspicion and you can rule out other possible sources or causes which can cause this clinical picture, still patient can have a disease, and we have to keep them on isolation until definitely ruled in or ruled out. As I briefly mentioned about the treatment modalities, right now on top is hydroxychloroquine and azithromycin. Now we have been using on all patients. Remdesivir is available for investigational trials still, only on ventilated patients. Once they go into ventilator, they are eligible to be enrolled in the study. We still have to see the data if it's how much efficacious, how much is efficacy of this medicine. I will stop here, and we'll go into question answer session. I think probably that would be more interactive, and I would be glad to answer any question. Thank you.
Very good. I think I was thinking of reading the questions that have been posted, but I think it would be more interesting if I just allow the people who are asking questions to speak the questions themselves. So I have a question from Dr. Mariam Moteen, actually two questions.
Yes, Assalamualaikum. I wanted to know what kind of pulmonary damage does it cause to affect the O2 diffusion exchange problem that we may be worried about or wanting to see corrected before it gets too late?
Very good question. Actually, we are familiar of this kind of picture as ID physician with the pneumocystis pneumonia. Most of the viral infections, even the influenza, when they cause pneumonia, they cause is we call it pneumonia, but it's like a pneumonitis. So it is interstitial inflammation, interstitial thickening. So it's a diffusion defect where oxygenation of the patient is impaired, and when it's like in the severe condition, it goes into the ARDS. So basically, it's the interstitial inflammation of the lung tissue that impairs the oxygenation.
Dr. Moteen, you had one more question.
Yes, I had another one. What we've been noticing patients are having fairly normal systolic function. The question is does it affect somehow the strain pattern of the LV? Do we know? Do we have any idea about that?
I'm not sure about that. I'm not, maybe one of our, some of our cardiologist colleagues, they can shed light on that. But I can, that what we see, the cardiac impairment in severe sepsis. So basically with the release of cytokines that impairs the myocardial contractility, and of course LV systolic function is impaired. And that's when they drop their blood pressure. But I'm not expert on that, so I'm not 100% sure. Thank you. And the third question, I can answer that. What is the PCR result turnaround time? Actual turnaround time is 3 to 4 hours. That takes the time for the test. But usually once they use that machine, they can run 50 tests at a time. When they run that test, they cannot use that machine for the next 24 hours. So actual turnaround time depends upon the frequency that specific institution they run the test on the machine. So in our institution, I can tell you that initially when there was few cases, we were having a turnaround time in 3 to 4 hours. Right now, there are more cases we see, so they run all those in batches. So we have a turnaround time 24 hours. With the CDC, because there's a huge backlog, so their turnaround time is about 4 to 5 days.
Very good. I see there is a question from Shazmi Khan. Let me unmute Dr. Khan. I am not able to unmute Dr. Shazmi Khan. Maybe the microphone is not connected. But the question was that when we're testing for COVID-19, are we testing for antigens or antibodies or a specific segment? What exactly are we testing?
Right now, we're testing the PCR, which is pretty sensitive. There is the antibody test also has been approved by FDA recently, but we have not started using in our institution that test yet. And that has, I think, a turnaround time for that test is a lot quicker than this PCR. But I anticipate there must be some false negative tests with that also. But I cannot comment for sure because we have not been using that test yet.
In PCR test, Dr. Sajid is testing the DNA or RNA fragment of the virus?
Yes, it's RNA. Well, I'm not sure the DNA or RNA, but nucleic acid.
And it has to be amplified enough so
Exactly.
that it's detectable.
Yes.
I see. And then I see a comment from Dr. Fawad Choudhary. Dr. Fawad, please go ahead.
Yeah, I think, Assalamu alaikum, first of all.
Right.
I think there was a question about ARDS and fluid management in COVID patients. A couple things there. First of all, thank you, Sajid bhai, again for the nice presentation. So these patients are going into ARDS rather quickly. There is a very good response to proning. That is again to shift the infiltrates, which are mostly in the posterior and basal aspects as opposed to anterior aspects in general. Regarding fluid management, this is in cohort with rest of the ARDS management. We always keep them dry because alveoli are kind of filled with fibrinous material and more fluid in simple terms. So with ARDS, the purpose of decreasing fluid intake despite normal function is to keep the lungs dry. And at the same time, we prone them to shift the fluid and make the ventilation perfusion oxygen. The alveoli, which becomes filled with the fluid and fibrinous exudate, they cannot oxygenate. So you move with those infiltrates by early proning them for 16 hours so that there is a good oxygen going into the blood surrounding those alveoli. At the same time, decreasing the water intake or keeping them dry with a CVP of 4 to 6. You make sure that enough fluid is not in the lungs to decrease the diffusion of oxygen to the blood. So that's the basis of the basically keeping them dry for ARDS. And very important again, early proning helps. Some patients we got, most of them got better with early proning. If there is any other question pulmonary wise that I missed in the section, please let me know. And if I answer the question, let me know if there's anything else, please.
Thank you, Fawad. If anything comes up for ARDS or pulmonary wise, I will definitely get back to you. Thank you.
Sure.
So next I have Dr. Zeenat Safdar. Let me unmute Dr. Zeenat if I can. I'm not sure if your microphone is connected. All right, Dr. Zeenat, go ahead.
Ji, Assalamu alaikum. Thank you so much for this, putting it all together. I think this is very commendable and very timely and very needed because there's a lot of even misconception over here and also in Pakistan. But my question, I was on a webinar this morning with physicians from Wuhan, Shanghai, through American College of Chest Physicians, and they were presenting data on the use of hydroxychloroquine and also the combination of hydroxychloroquine and azithromycin. So there is a lot of data on hydroxychloroquine, but not much data. But actually, they were saying that using the combination should not be the standard of care and should be used in caution. But you mentioned that you're using it more routinely.
Yes, actually, again, we don't know any controlled randomized trial to showing the efficacy one way or the other. From the China, you're right, there's more data about the hydroxychloroquine. There's a small study from France, which showed the efficacy of combination of azithromycin and hydroxychloroquine. Yes, by using combination of both, there is an increased risk of cardiac arrhythmias that you take. I've been using both because when we have monitored the inflammatory markers, I have seen that I don't know how much is the addition by the azithromycin, but there's again is the anti-inflammatory effect of from the azithromycin also. So we see the nice decline in the inflammatory markers. I have used so far without any side effects, but of course you have to get the consent from the patient. I always explain to the patient these are the options and what would you pick from either one or both. And most of my patients they pick both. So I have been using both.
Okay, I think Fawad has a comment on this question too. So Fawad, please go ahead.
Yeah, quickly, as mentioned, the cardiac effects in QT prolongation. So what we are doing is we basically do the simple EKG, and if QT is borderline, we still go and we follow it up. But if QT is prolonged, so we are holding off the throw. So just a simple comment on that. So just watch for the QT. Data-wise, as Sajid bhai said, and as was said, we still have to know, but anti-inflammatory effect is the main reason we're using it.
Thank you, Fawad. So I'm going to keep going with the questions, but I wanted to again say that I'm noticing every question. Anybody who's raising their hand, I can see it. I'm trying to go one by one in order. I'll try my best to be in order, but I apologize if I miss someone and to go to them late. But my hope is that I'll get to each one eventually. So I have Dr. Ijaz Khan next. So let me see if I can find Dr. Ijaz and unmute him. Ji Ijaz bhai, let's go ahead. Dr. Ijaz, you're
Hey, Assalamu alaikum.
Assalamu alaikum.
Walaikum assalam. Thank you very much for this great opportunity. बहुत अच्छा इनिशिएटिव है आपका और ये थ्रू आउट जो इस पीरियड में आपने ये इसको अरेंज किया, इट्स रियली अप्रिशिएटेबल. Thank you very much for that. बहुत अच्छी प्रेजेंटेशन थी. I kept listening to silently. आजकल ये काफी डिबेट चल रही है. वैसे बहरहाल मैंने जो क्वेश्चन पोस्ट किया है वो तो वायरस की म्यूटेशन, पॉसिबल म्यूटेशन के ऊपर है, इफ देयर इज एनी एविडेंस. लेकिन ऑफ कोर्स ये जो साथ में दूसरी कुछ और भी कोलीग्स ने जो क्वेश्चन किए हैं, द यूज ऑफ हाइड्रोक्लोरोक्विन की और एक्यूट से कहते हैं, और साथ में एजिथ्रोमाइसिन की कॉम्बिनेशन और भी सजेस्ट की जा रही हैं. इवन आज मैंने ये भी सुना कि जो इंटरफेरॉन है वो भी क्यूबा में शायद उन्होंने ट्राई किया है, उसके भी प्रॉमिसिंग रिजल्ट्स जो हैं वो मिल रहे हैं. तो ये हिट एंड ट्रायल तो चल रहा है और कुछ प्रॉमिसिंग रिजल्ट्स भी आते हैं. इसमें कितने % चांसेस हैं कि ये मेडिसिन ही इफेक्टिव है और ये पेशेंट होस्ट का अपना इम्यून सिस्टम या उसकी और जो फैक्टर्स हैं वो किस हद तक इसमें रोल प्ले करते हैं? आया ये एक ही किस्म के ग्रुप्स पे, एज ग्रुप पे यूज की गई हैं मेडिसिन या डिफरेंट एज ग्रुप पे की गई हैं, और इसमें यंग ग्रुप में और ओल्ड ग्रुप में क्या डिफरेंस है? तो इसके ऊपर कोई आपके पास कोई? थैंक यू.
जी, this is Dr. Sajid Choudhary. A very good question actually, Dr. Ijaz. The true answer is no, we don't know yet. So it's all anecdotal data. There's no controlled trial where we can definitely show this efficacy of the one, even hydroxychloroquine, azithromycin, or combination of both. Again, I will mention that you're absolutely right. I have initially I was using criteria of the requirement of oxygenation. If somebody is on requiring oxygen, I was using hydroxychloroquine and azithromycin. If the patients who even the chest X-ray or CT was showing diffuse interstitial infiltrate, but patients they were not hypoxic, stable on room air, I was not using any medicine on those patients other than supportive care. अब बात आपकी बिल्कुल ठीक है. वो जो पेशेंट थे वो भी ठीक हुए, जिनको हाइड्रोक्सीक्लोरोक्विन और एजिथ्रोमाइसिन दी वो भी ठीक हुआ. और एक पेशेंट मेरा मतलब आई हैव एक्चुअली 4 पेशेंट हु गॉट इंट्यूबेटेड. सो एक पहला पेशेंट जो इंट्यूबेट हुआ तो आई वाज गिविंग हिम हाइड्रोक्सीक्लोरोक्विन एंड एजिथ्रोमाइसिन, but on third day he went into ARDS and intubated and unfortunately expired after 48 hours. So the answers to your questions, no, we don't know. Is their immune response making them better or recovery phase, or is because of the combination of these hydroxychloroquine or azithromycin. One thing definitely we know from the clinical picture we have been seeing from China and European countries and even USA also some, that there's recovery is about 90%. So if the 90% of the patient, they are recovering from this disease spontaneously, so there must be their immune response is responsible for the clearance of this virus. So definitely there is a huge factor of immune response development of the human body, and that is the reason is being used. The next step is plasma, to give the plasma from the recovered patient. And I think, if I'm not wrong, the first patient they have tried or they're going to try in Houston, they are using the plasma from the patient who recovered from the disease and for the infected patient. And similar, I think, strategy is being planned in New York also. Because but the only problem here is they have to make sure the patient has recovered completely. So we don't have that many patients who have recovered, but China has more patients who have already recovered. So I'm not sure about if they are working on these lines or not yet.
Any comment on that interferon, Sajid?
Again, there's another one also being tried in only on ventilated patients. So we are not, I'm not using that, but on certain centers here in Orlando, they're only reserved for ventilated patients. So how much is impact or effect of that is yet to see. The problem is on the ventilated patients, mortality is extremely high. It's like over 60%. Whether it will be effective or not, it's still yet to see. But it's being used, definitely.
Very good. So before I go to the next question by Dr. Harikar, I think Dr. Awais Masood has a comment on it. So Dr. Masood, please go ahead. Dr. Awais, you're unmuted. Please go ahead.
Dr. Vyas has actually vast experience dealing with the critical care patients from the COVID-19.
All right, I'm not able to hear Dr. Awais. So I will go to the next person in the queue, which will be Dr. Fiza Harikar. I hope I'm saying the name right. Let me.
Yeah, Assalamu alaikum.
Please go ahead.
Assalamu alaikum. My name is Fizia Harikar, and I have so many questions, but I'll settle for two for now. First is, what has been your experience, or do you have ever given tocilizumab? And my second question is the use of NIV and nebulization in patients who are near intubation. So we have not been doing that, and in fact, those who are progressing with very rapidly, we have rather gone for elective intubation than trying to give them NIV, as previous studies have shown that they have a bad prognosis and increases the risk of aerosolization.
I will answer your second question first. Actually, could not get the first question. So you're absolutely right. We are not using non-invasive ventilative support or nebulizer treatment. All patients, they are getting, if they need, they are getting just regular inhaler puffs. When they are going to near intubation, but I am seeing they go rapidly deteriorate and go up to the level with when they need intubation. So at that point, even if I think we will try, I don't think, in my experience, it's going to work or be effective. But we'll be taking a chance of more aerosolization of the virus. So in our institution, we are not doing that. We just use the oxygen via nasal cannula, and at the most high flow nasal cannula, which is also in some institutions it's not recommended, and then go for elective intubation after that. So I'm sorry, I missed your first question.
I asked about tocilizumab. Have you had any experience with Actemra?
No, I don't have any personal experience with that, but I have heard from my colleagues from other institutions here. Yes, there's in certain patients, selected patients, they are using that also. But again, how much is efficacy, still we have yet to see.
Very good. So I think there are a bunch of experts we have who also can add to this discussion on non-invasive ventilation. So I will go one by one. Let me try Dr. Awais again. Dr. Awais, please go ahead. So I'm not able to hear him. So let me go to Dr.
Fawad Choudhary, I think he's...
Fawad Choudhary. Let's see. Fawad. Fawad, please go ahead.
Can you hear me now?
Yes.
Okay, so I feel bad for Dr. Abbas. I think he could have commented on these things as well. So first of all, regarding NIV and high flow, I totally agree. There have been multiple studies that have been done prior. So there is some confusion about how much oxygen you can use without much aerosolization. Up to 30 liters of high flow is accepted. However, that has been changed even with the pulmonary guidelines as well with the chest. Current recommendation is that to intubate as soon as possible, because even if we use 10 liters or if we go to the high flow with less aerosolization up to 30 liters, there is still chance of some aerosolization because virus stays in the air. And intubation under PEPPER full control is much better. And then secondly, these patients go into rapid ARDS, as has been pointed out. So our institution and many other institutions are shying away in suspect. Positive is easy. We are intubating early. But even with highly suspicious, we are going into early intubation by expert attending and or anesthesia. We are not letting fellows do that to avoid exposure. And that too is being done mostly with the video laryngoscope as opposed to direct. But again, as long as protection is done, that's okay. That's one thing about NIV is to shy away. Secondly, NIV is mostly beneficial in hypercarbic respiratory failure. Most of these are hypoxemic. So again, the benefit of NIV, especially talking BiPAP, is not that much proven. But regardless, these patients are going for early intubation. Number two, regarding TOSI. So TOSI is basically a place comes where you have cytokine release syndrome with the immunity. It usually is commonly previously seen in leukemic patients, but that has been seen in those patients with a very high mortality. These patients die with cytokine release. Usually being seen in 6 to 8 days time frame. So what we do is when the patients are doing into multi-organ failure, we check interleukin 6. If the level is above 400, we are giving TOSI. So we have given one TOSI to one of our patients actually yesterday, and the response has been great. And it coincides with some of the studies in Chinese. Within 3 to 4 hours, there was improvement even in the chest X-ray as well as in hemodynamics. So far with one patient, our personal experience with TOSI has been great. It was too good to be true. But this patient met all the criteria, including multi-organ failure, rapid deterioration, and then his IL-6 levels were high as well. So again, I think these are all uncharted fields right now, like Vitro and chloroquine. If I would say the way we are looking into, if some person is going into acute lung injury to ARDS, we are not only giving them the combination of hydroxychloroquine and Vitro, but we are also considering early possibility of using TOSI if they're going to CRS. Remdesivir, we have not tried it. That's what I wanted to ask Sajid Bhai's experience with that, because it's gone to the trial and I don't know how long does it take. Again, we don't know the response, but personally, we have not tried it in our patients as yet. Thank you.
Sajid, remdesivir?
As I think that's Dr. Fawad Choudhary mentioned about the impact of the dramatic impact of the TOSI, but we are not seeing that remdesivir. So again, it's hard to tell whether the patient is improving with that because patients have been dying of remdesivir, and some patients they are improving on that also. So clinically it's hard to tell it's effective or not at this point.
Okay, thank you. I have at least 3 other questions from Pakistan, but before I go to them, let me quickly get comments from Dr. Kaleem Ahmed, another ICU pulmonologist we have. Dr. Kaleem, please go ahead.
Thank you very much for this nice presentation. I think a lot of people are jumping in and providing the right information. Inshallah, I will go over the guideline in detail for all of things on Saturday. I want to ask Sajid about the media report on how this virus is affecting different countries differently. There's many kind of stories going on. There is a recent report correlating the BCG vaccination in population on different part of the world versus not having BCG vaccination, and it's showing some kind of positive benefit. If you think about Pakistan, that's a kind of little silver lining. Any comment, any idea from the infectious disease perspective about the protective nature of BCG in this coronavirus COVID-19?
Again, we have to prove it, I think, scientifically, but it's like, as you mentioned, it's just like observational. It's observation, it's not even study. That's the disease is not spreading that fast in those countries was routinely vaccinated with BCG. I'm not in a position, it's difficult to tell that exactly because we have yet to see the peak in those countries. So if we start falling from China, China's peak, after that is Italy, and then the European countries and the US, is like we are expecting our peak in Central Florida in the first week of May. So unless all the epidemiological data is collected, it's hard to tell that it is affecting or it's not affecting. Because in the countries like Pakistan, I think there's peak they're expecting in the next maybe 4 weeks. There'll be more cases there. So answer to your question is I'm not sure about that. What's the scientific data behind that? But we will have to see after we pass over this pandemic, and then we can definitely will be able to say that. Thank you. Actually, I would like to hear from Dr. Wes Masood if we can connect him, because he has a lot of experience and probably we can benefit from his words.
Dr. Awais, can you hear us? Can you try to speak? Maybe your microphone is not connected with Zoom.
Oh, is muted?
I've unmuted him, but his microphone is not working. Waleed, can you reach out to Dr. Awais and see if you can help him connect the microphone? Meanwhile, let me go to Pakistan, and I have a question from Dr. Noshaba Habib. So I'm gonna unmute Dr. Noshaba and let her give her comments and question.
I had a very quick question. I wanted to know who is more susceptible. They keep saying older people and people with comorbidities, but I read an article that said that older people have higher immunity, as a matter of fact, and chloroquine is undoing that immunity to treat them wherever it has been beneficial. So I was wondering if there is many mutations of the virus that even younger people are dying, that they have a different mutation, or is it anything to do with concentration? Again, I'm ignorant on it, so I would like your input on that.
Actually, Dr. Noshaba, be very good question. And we're also, as we go through this disease, face the patients, my experience is also actually younger and older. They're all being affected or infected almost at the same ratio. I've been seeing the patients, younger patients going rapidly into ARDS and respiratory failure. I've been seeing older patients, they are stable on minimal requirement of the oxygen and they are recovering from this disease. So I agree with you. We don't have, again, we need some more study and more scientific data on that. Which subset of the population age group is getting more effective or protective. Regarding your question to change of the mutation and the different strains, there was another question before that. Again, there like initial strain which jumped from the animal to human was the S strain. And during the process, I think it changed. Now we're seeing more of the L strain. Initial strain was not that aggressive or lethal, we can say, but this the L strain is the more aggressive and lethal, rapidly progressive. So that's why I think we have less. I don't know if it's reported less or actually less number of casualties in China as compared to Italy. We are seeing a higher death rate in Italy, and even Spain or the European countries. In the US, it's actually less than China, but I don't know if it's due to more aggressive medical management, because the critical care management, of course, is way aggressive and better in US as compared to in the rest of the countries. So it's hard to tell how many different strains are circulating, but there's always possibility different strains are circulating or mutating, and that's why we're seeing the different cases in different geographical regions.
Thank you, Sajid. So I see a few questions from Dr. Mariam Moteen, so I'm going to unmute her.
Danish, do we try to keep the lungs dry and go for proning? But how do we deal with the hypotension? Have you looked into giving them any kind of vasopressors or versus fluids in helping those patients?
Dr. Fawad Choudhary, I guess.
Let me get Fawad. Fawad?
So sorry, I missed the question.
So the question was that when we're keeping the lungs dry and go for proning, but there is concern about hypotension.
And is there any role for any kind of pressors in that cases?
Any role of what, sorry?
Pressors.
Pressors, yes, exactly. So I think that's exactly what we do. We are going into early pressors. As long as they are not going into 2 or 3 pressors, we should be okay. As I mentioned, that most of the times, if it is COVID only, with possible superinfection, they are reverting rather soon out of ARDS. So in 24 to 48 hours, despite keeping dry, you're kind of on a low to medium or high dose of vasopressor. One vasopressor is totally fine. However, if you keep seeing that the lactic acid, which is a marker of tissue hypoperfusion, keeps going up, and your ARDS, despite proning and keeping dry, is not improving, then we have to switch around and, give them fluid and then catch up again after improving the lactic acid. So it's primarily, you will be able to hopefully get them better, or at least bring their PF ratio down by using one vasopressor. But if it goes more than one, then I would suggest to kind of back off and give some fluid.
In the cases where you don't have any kind of, help with getting the PCR back in time, we had been looking at the white cell count and looking at relative lymphopenia to see if this patient should go in isolation or not. Do you follow that too?
Sajid?
Yeah, definitely. It's more of a clinical presentation. Of course, if somebody is presenting with the new onset of dry cough, shortness of breath, fever, without any other obvious bacterial or viral etiology, and all, we usually do respiratory PCR panel on all of those patients to make sure that they're not having influenza or other seasonal viral upper respiratory tract infections. Then after that, if we have inflammatory markers are elevated, like highly sensitive CRP is elevated, procalcitonin is less than 0.05 or negative, and ferritin is elevated, lymphopenia, yes, I put them on isolation. As I told earlier, mentioned earlier, that I have 2 of my patients who are still on isolation, and one was twice tested negative for PCR, and other one is 3 times we did the PCR, which is negative. So if a high clinical suspicion, yes, I keep them on isolation until they start recovering.
Very good. I think there is a couple of more questions from Dr. Mariam, but I'll come back to you. Let me go on to some questions and comments from Dr. Ijaz Khan. Ijaz bhai, please go ahead.
जी थैंक यू वेरी मच दानिश भाई। मेरा बेसिकली एक तो वो जीन म्यूटेशंस पे सवाल था पहला जो था कि वो साजिद भाई ने अच्छी तरह उसको रिस्पॉन्ड कर दिया। दूसरा जो जिस पे जिक्र हो रहा था या जिसका तज़किरा चला वो प्लाज्मा को यूज करना पैसिव इम्यूनिटी के लिए। पाकिस्तान में भी इसके ऊपर कोई एक दो साहब हैं जो कि वो इसको ट्राई करने की कोशिश कर रहे हैं। प्रॉन्स एंड कॉन्स हैं। थोड़ा सा लिटरेचर रिव्यू मैंने किया था तो ये पता चला कि ये बेसिकली क्योंकि नेचुरल इम्यूनिटी नहीं होगी तो लॉन्ग टर्म नहीं होगी, पैसिव इम्यूनिटी होगी और शॉर्ट टर्म के लिए तो ये काम करेगी। मेरा सवाल ये था और मैं ये समझना चाह रहा था कि जब ये शॉर्ट टर्म इम्यूनिटी होगी, लॉन्ग टर्म नहीं होगी, तो डिपेंडिंग अपॉन द नंबर ऑफ द पेशेंट्स हु रिकवर्ड आफ्टर दिस ट्रीटमेंट और पार्शियली रिकवर्ड, फुली रिकवर्ड और पार्शियली रिकवर्ड, they won't be going to have long-term immunity against the virus genome. So ऐसा होने के बाद फॉर इंस्टेंस कि वो एक क्लस्टर आपके पास डेवलप हो जाता है जो कि जिसके अंदर लॉन्ग टर्म इम्यूनिटी नहीं है वायरस के अगेंस्ट, और हर्ड इम्यूनिटी का कॉन्सेप्ट डेफिनेटली यूएस है, बहुत बड़ा मुल्क है, पाकिस्तान बड़ा मुल्क है, पॉपुलेशन डेंसिटी बहुत ज्यादा है। वो कंट्रीज जहाँ पे के पॉपुलेशन डेंसिटीज ज्यादा हैं या जहाँ पे बहुत स्पार्स है, दूर दूर लोग रहते हैं, ऐसी सिचुएशंस में फ्लक्चुएट करेगा कि कहीं पे क्लस्टर्स के अंदर इम्यूनिटी होगी ज्यादा, हर्ड इम्यूनिटी कहीं पे नहीं होगी इस वायरस के अगेंस्ट। नेचुरली कोर्स ऑफ एक्शन जो इसका है, ये कुछ अरसे के बाद बिल्डअप होके दोबारा ये वायरस जो है वो फिर म्यूटेट करके आता है। इन केस के अगर उसको विंडो मिलती है कि उसकी के अगेंस्ट नॉन इम्यून होस्ट पॉपुलेशन से मिलती है, तो क्या वो वहां पे आउटब्रेक नहीं कर सकता? ये लॉन्ग टर्म में क्या इस पैसिव इम्यूनाइजेशन का जो कॉन्सेप्ट है उसका एक कॉन्सिक्वेंस नहीं हो सकता कि हम नियर फ्यूचर में अगर हम इसको यूज करते हैं और फिर नियर फ्यूचर में हमें दोबारा से आउटब्रेक्स मिले और वहीं पे हम खड़े हों, हमें जगह जगह पे छोटे छोटे आउटब्रेक्स के एपिसेंटर्स मिल रहे हों? इस पे आप क्या कहते हैं? थैंक यू।
Dr. Jaskan, very good question. Actually, we all are thinking about on the same lines. As I mentioned, this natural immunity जो है इसके against वो 90+% जो है patient they automatically recover from this disease. तो immunity तो develop होती है, whether it's long lasting or not, we have to yet to see. जो मुझे feeling हो रही है, it will be exactly like influenza. सो एक दफ़ा जो पेंडेमिक आई है इसमें बहुत सारी कैजुअलिटीज़ होंगी, डेथ्स होंगी और स्टिल मोस्टली पीपल रिकवर। जो प्लाज्मा की ट्रीटमेंट है दैट इज़ ओनली रिजर्व्ड फॉर क्रिटिकली सिक पेशेंट्स, क्रिटिकली इल पेशेंट्स, और फॉर टेम्परेरी टू गेट बियॉन्ड दैट क्रिटिकल पीरियड। और उसकी जो यूटिलिटी भी है इस इन क्रिटिकल केयर सेटिंग, इट नॉट लाइक अ नॉर्मल आप रूटीन में आप फ्लोर पे पेशेंट है उसको आप यूज़ करेंगे जब ये यूज इवेंचुअली यूज होना शुरू होगा। तो अल्टीमेट इसका सॉल्यूशन होगा वैक्सीनेशन। यूएस में आई थिंक देयर आर 3 or 4 companies who are working on this vaccination, and if I'm not wrong, I think we are maybe somewhere 4 to 8 weeks away from the development of the vaccine for about this for this virus. So मुझे जो feel हो रहा है कि it will be exactly pattern like influenza चलेगा। Every year we might have to come up with the vaccination and then vaccinate a lot of people and then develop some herd immunity. And of course, some people, they always will be there with lack of immunity or lack of course, vaccination, and there will be a certain pockets of outbreak in the future. But again, we have yet to see. Thank you.
Thank you, Sajid bhai. So before I go to the next question from Pakistan, I saw that Dr. Rizwan Khalid had raised his hand. Rizwan bhai, please go ahead.
So do they have to unmute on their screen also, or you can?
I think I can, but sometimes it works and sometimes it doesn't work. Ji Rizwan bhai.
Hey, assalamu alaikum. Finally, I think I was trying to unmute, but kept on You have to do it. So, Assalamu alaikum, everybody. This is Dr. Rizwan Khalid, President-elect of APPNA. First of all, I want to just thank Shahid and Danish for actually putting up a great show, and all the panelists for attending. And I certainly wanted to congratulate all the attendees from Pakistan as well as the US. एक चीज़ मैं ज़रूर कहना चाहूँगा कि अगर तारुफ हो जाए लोगों का ना, like a brief, like whoever it is, ABC, I'm pulmonologist from wherever, Tampa, or I'm XYZ from Aga Khan in Karachi. That would be very good for us to know where somebody is coming from. Many of the panelists, we know each other very well. Like I know Wes very well, Sajid, but there are a lot of names that are unfamiliar, and it is much better to know where somebody's specialty is and institution is, so that we can certainly answer the question much better. So, I just want to give one comment and try to get as many questions as possible from Pakistan, because so certainly this aim of this particular seminar in the middle of the night is to benefit as many physicians in Pakistan. When I raised my hand, Danish, it was a long time ago. I wanted to briefly say something about the QT prolongation and everything that I'm a cardiologist, electrophysiologist. So I want to quickly mention about that. But you know what? I think we should take questions from Pakistan. And then in a couple of days, when I'll do my talk, I will mention the QT prolongation issues with treatment. Thank you very much, Ji.
Bilkul sahi. Thank you, sir. We're looking forward to your talk. So I'm going to go to Pakistan, and I see there are a lot of very good comments from Dr. Harikar, Physia. So let me unmute Dr. Physia and have her make comments and a question. Please go ahead.
Yeah, so I just wrote a couple of things about BCG, because it has been used in France, Italy, and China, and you have seen a lot of cases going over there. So I don't think that BCG is something which is going to be very beneficial in preventing the cases in going up or increasing the severity. I just wanted to share that we used tocilizumab in 3 of our patients, and the ARDS, I mean the X-ray was like magical. However, having said that, there was only one patient who is around 48 years old, and he's still on the vent. The other was 70 years, and he just expired yesterday. So we're just trying. We don't have remdesivir, and yes, there is some trial, and we can achieve that. We're not using lopinavir. We are using HCQ in most of our patients who need oxygen supplementation, and not for the regular ones. So I feel that there's much to understand with whom you can use tocilizumab, and what it can produce, what side effects or how it can. So this guy with 48 years old, he did really well. His ventilated parameters started going down. However, for the pulmonologist, I mean, with all the settings we had, he started retaining and CO2, and eventually now I think he's developed a nosocomial infection. So I'm scared that we may, not have a very good outcome of him. I'm also very I have a question about deciding code on such patients who are elderly, and it's very difficult because if a patient is getting better and he's very elderly, 70 plus, 80 plus, and then he develops AKI, and whether to do CPR, I mean, you go full board, you're on, the patient is on ventilation, but you don't want to expose. We don't have negative pressure rooms. We have created our own, like we put in HEPAs and UV lights and sort of an N95 filters. But the thing is, just to prevent a lot of exposure to the healthcare workers, I have a feeling that I don't want to go for a full go CPR process in those who have a age against them, or who've been on vent for a couple of days. But on the other hand, if they go into AKI, the nephrologist says that if you're not going to do CPR, we won't do dialysis. So these are confusing situations that we are, because it's beginning to build up in Pakistan. And I'm from Indus Hospital, so I'm an infectious disease specialist at Indus Hospital. So I just had these couple of things going on in my mind day and night these days.
Ji, Shahid bhai.
Dr. Harikar, I think they're all questions that you have raised, very valid and practical questions that we have to face when we deal with the patient towards the end of the life care and to make decision at that point. And I think those decisions are made on case-by-case basis. Here in US, we in a different situation. We never stop doing anything until there is some DNR or withdrawal of care support. Other than that, patient, they go through the CPR or they need the dialysis, they go dialysis or ventilator and then prone or and ECMO and then you guess what not. But in Pakistan, I think, of course, you have to look at your resources and then take a decision accordingly whether you want to spend your resources on futile cases or you want to spend your resources on the cases where you can have some benefit. So it's I'm unable to react to that question. It's up to, I think, local circumstances. I would like to comment on one question, which is a very good question from Dr. Morton regarding the N95 use, which will be in Pakistan. As chair of APPNA COVID task force, we are working to provide N95 masks and surgical masks and gowns in the different institutions in Pakistan. Mostly we're getting requests for N95 masks from all over the institutions there. Which is not that much available in Pakistan. So N95 mask is not mandated by CDC guidelines. CDC guidelines, the surgical mask can be used for the mildly symptomatic patients who are not producing aerosols, who are not having cough. In our hospital, we use N95 mask. Yes, it can be reused. One nurse or one physician uses one N95 mask for a whole day. So this is reused until towards the end of the day. We protect N95 mask by covering it by a surgical mask. So you come out of the room, you remove the surgical mask and keep your N95 mask. Regarding the use of N95 mask for my Pakistani colleagues, N95 mask is fit tested individually. So until unless you are not fit tested, probably you may not be able to, you may not know which size will fit you the best. So in US, we all are fit tested, all physicians who are working in the hospital. So you know what size will be good for you. So in Pakistan, I don't think there is a mechanism that they can be fit tested. So the utilization of the N95 mask may not be that effective in Pakistan until unless they are individually fit tested. So I will recommend, yes, if you have an N95 mask, you can use that. But the surgical mask with the good covering and then with the face shield will be as effective as the N95 mask. I will stop. Thank you.
Thank you, Sajid. I want to make a comment that thank you, Dr. Fizia Harikar, for introducing yourself. We'll try to get better at this. This was our first webinar. We'll try to get introductions. Just like Rizwan Bhai said, that was a really good idea. We would love to see who is participating, especially somebody like Dr. Harikar, who is at the front line of treating the COVID patients in Pakistan. We are here for specifically people like you to help answer specific questions you have or support anything. I'm going to try Dr. Awais Masood again and see. Dr. Awais, please see if you can speak to us. I'm not sure what technical issue is limiting. I'm going to leave you unmute, and if you get successful, please go ahead and jump in at any point. There was a question from someone, I think, attending from Facebook or somewhere, because I don't see him in the list of attendees. Harun Iqbal, do you see that question, Sajid Bhai? It's about role of ACE2 inhibitors in treating COVID-19 infection.
Yes, I saw that question. Actually, I think I scrolled down. Actually, it's not the role of ACE inhibitors in the treating. I think it's the other way around. There's not like control studies, but the patients who are on ACE inhibitors, they are at higher risk of acquiring the disease. Whether it's true or not, we don't know yet. We need to have the studies. So it's the other way around. People on ACE inhibitor at high risk of acquiring the disease.
Interesting. I see a hand raised from Pakistan next, Dr. Noshaba. Please go ahead.
No, I'm not in Pakistan. I'm sitting right here in Houston.
Oh, okay.
And I'm an anesthesiologist, and I'm an older anesthesiologist. I do contract work, which is just day surgeries, which is all suspended right now. And I'm being asked by one of the day surgery people who've converted a floor into COVID-19 to come and volunteer. So my question was that they're wearing protective gear completely, COVID-19 and then the whole gown thing and the face shield and all. How are you likely to infect yourself if you're completely covered?
Is highly unlikely, actually. Of course, if you'll be working in that unit with the ventilators, so there's a high risk environment, of course. But if you are covered with the protective gown, face shield, and 95 mask, it's highly unlikely that you can have infection.
Very good. So I see a question from Dr. Akhtar Munir. Let me see if I can invite him to speak.
Naresh bhai, I can have another, I can share my experience with our audience. Patients now, because the disease is so widespread, and we are getting patients with the other symptoms or problems, and then they are tested positive for COVID at the same time. I can share the experience. One patient who presented with acute pyelonephritis, typical septic picture, was treated appropriately. She got better, and 3 or 4 days in the hospital, she started spiking fever again and developed some dry cough. At that time, we suspected probably she had a COVID-19 disease, coronavirus disease. So she was tested, and she tested positive. So including myself, rest of the staff, they were exposed to that patient for at least 3-4 days. Luckily, that patient was neutropenic also. So we were using neutropenic precautions. We were using the surgical mask in any way. She had one of the multi-drug resistant bacterial infection previously. So we were using gowns also, contact isolation in any way. So none of us has been symptomatic. So, and another patient who presented with the DKA and acute pancreatitis. So he was treated for that, new onset of diabetes mellitus, DKA, hypertriglyceridemia, pancreatitis. Everything leads towards that he had a pancreatitis due to hyperlipidemia. Then he got better, and then continued having a low-grade fever. Initially was thought from the pancreatitis. Then again, we just out of blue, okay, let's check him for coronavirus, and he tested positive. Again, including myself, about maybe 5 to 10 people, they got exposed to him for 3-4 days. Again, we're just monitoring ourselves. Everybody's fine, and the patient is also fine. So that those situations will come across. That patient is coming for MI, for cardiac, for the CHF, but still they having COVID-19 disease also. So we don't know, we don't have any experience with that, but we are more careful for any patients who are admitted in the hospital. Thank you. I will stop.
Dr. Akhtar Munir, please go ahead.
Assalamualaikum.
My
question was, what is the false positive rate in the PCR?
I'm sorry, I missed the question.
The question was, what is the false positive rate of PCR? How likely it is to be false positive?
Cannot be. I cannot think that can be false positive.
Can it be false negative? Can it miss an infection?
That can happen. That's why, as I mentioned, shared my 2 patients. They are clinically highly suspicious for coronavirus disease, but they are negative. So we're not sure whether false negative because of that this virus is not present in the nasopharynx there, and maybe down in the lungs. As I mentioned, there's few cases in China that were diagnosed on the, I think, a third or fourth attempt later on with the deep respiratory samples. So false negatives is chance, but false positive, I don't think is highly unlikely.
I see. I have a question from Dr. Abdul Naeem next. Let me see if I can get it from him. So the question is, I'm not able to unmute him. The question is, what are reasons of high mortality in US and European countries than Asian? Actually, Abdul Naeem is unmuted. Please go ahead, Abdul Naeem. Okay. We're not able to hear from him. So the question is, what are reasons of high mortality in US and European countries than Asian?
Well, we don't know yet. I think maybe better diagnostic facilities or capabilities. More and more people, they're diagnosed and labeled as death from the coronavirus disease. But definitive answer, we don't know yet.
No genetic or ethnic relationship that we know of?
Again, we will see after this pandemic is over. So we have more data and studies available, and then probably we will be able to predict what was the reason behind the high or low mortality.
Okay, I have a hand raised by Dr. Shahzad Khan. Dr. Shahzad, please go ahead.
Hello, thank you. I'm Dr. Shahzad Ali Khan and in Health Sciences Academy, Islamabad. I just read somewhere that there is a specific neutrophil to lymphocyte ratio, which is the first thing which changes in case of this COVID. Is it valid or has been observed, or is just because there was some research and a lot of findings from China that the first thing which shows in the simple blood picture, CBC, is the neutrophil to lymphocyte ratio. And number two is the first symptom which a person has when he or she develops this disease is the change in smell, anosmia, and sort of taste feeling. So we are having a lot of description from the patients who have recovered or who are admitted that the first thing they started feeling was a different sense of smell and a little different taste in their mouth before anything else. Is it true?
Dr. Shahzad, very good question. Actually, this I forgot to comment on this segment. Your segment. Yes, actually, I have been noticing also. Initially we were not that much aware about this effect. As we go through the disease, we are learning also. So when we deal with the patient, yes, more and more patients, they are getting, when we ask specifically, yes, the loss of taste and smell. And actually in some patients, I've been seeing a loss of appetite also. So I don't know as the reason with the loss of taste, that's the reason for the loss of appetite, or just because of the inflammation in the body. Regarding this first question, if you can repeat, I kind of missed the first question.
It was the neutrophil to lymphocyte ratio.
Yes. Yeah. So what we have been observing here is the lymphopenia is a pretty characteristic of most of the cases. But to me, this feels like this disease is just like TB that we used to see in Pakistan that can present in any way. Today we have diagnosed with the COVID-19, and actually he has a ratio other way around. Lymphocyte like a 60%, neutrophil like 30 or 40%. but most of the patients, lymphopenia definitely is a predominant feature. Again, I have seen the patient with the inflammatory markers like a CRP, highly sensitive CRP, in the range of like maybe 5 or 10, and some patient like you see in the range of like 300. So it's such a variable pattern. You cannot predict the certain way, okay, this is the one that you see. But most of the patient, dry cough, shortness of breath, that's a typical symptoms. And with the lymphopenia, elevated CRP, elevated ferritin, that I'm seeing almost across the board. All others are like a variable picture. So it's hard to comment exactly which one is like more characteristic. Thank you.
Thank you, Sajid bhai. So I have a question from Dr. Abdul Jalil Khan. I'm not able to. Oh, Dr. Abdul Jalil, please go ahead. You're unmuted.
Assalamu alaikum. My question is, I'm basically leading the telemedicine project in Khyber Pakhtunkhwa from KMU. We're getting a lot of questions about this passive immunity thing. I'm not sure whether you've already discussed it. And last night there was news from Dr. Shamsi from Karachi. So any update, like, in America, that's number one. The second is about prophylaxis use of hydroxychloroquine, because I'm getting that question mostly from healthcare professionals. So if you can just please talk about that.
Ji, thank you very much. As I think we discussed that's passive immunity earlier. In US, yes, definitely they are working on it. I think the first shoes will be, which I heard that first shoes is coming from Houston and then the New York State. So they are waiting for the people or working on the people who have recovered from the disease. And because we are in the midst of this pandemic, so we don't have that many people who have recovered from the disease and are able to, you are able to use their plasma. But definitely that's I think there's a future for the acutely sick patients or critically sick patients, that they will be being treated by passive immunity by plasma use. Second question regarding the use of hydroxychloroquine. I am getting calls from all my friends, relatives, colleagues, non-ID colleagues about the prophylactic use of chloroquine. We are not recommending at this point. We don't know, actually, we don't know whether it works in infected patient or not. Though there is some anecdotal studies and data that's probably it is somewhat effective, and that's why we're using it, because we don't have any other option available. But personally, I'm not recommending for prophylactic use of chloroquine at this point. Thank you.
Dr. Akhtar Munir, please go ahead.
Assalamu alaikum.
Ji, please.
My question was, some of the COVID-19 patients present with shortness of breath, and they are also having changes in ACG and rest troponin. So how to manage them, either to manage them as myocarditis or as ACS?
I will leave up to my cardiologist colleagues to.
Rizwan bhai, let's see if he's still here. I don't see Rizwan. I think he left. So we may have to wait for another day. I think he's speaking.
I can share with you my experience as one of my patients presented with syncopal episode and found to have some cardiac arrhythmia and tested positive for COVID-19. He is stable clinically, but my cardiologist colleague, they are waiting for ID clearance for this patient. And of course, you cannot clear this patient. It's not cleared from isolation, at least for 2 weeks. So they are reluctant to do any procedure on that patient. But I will have if any cardiologist can comment on that.
Okay, we'll see if someone replies. And I have a question from Dr. Abdul Naeem. Abdul Naeem, please go ahead. The question is on any role of vitamin C or minerals or any other supplements.
I think we are using it, vitamin C and zinc also, magnesium also, but if it has some role or not, we yet to see, but I don't think there is any harm of using that.
What doses are you using for vitamin C and zinc?
I
Just
don't.
routinely
Yeah,
dosing.
I don't have on top of my head, but it's like we have a power plan, which mostly we use in the US. So I have to recall. I have to figure it out.
Okay. All right. I don't think that we have. Well, I have some questions from Dr. Mariam Moteen, so let me give her the mic. Dr. Mariam, please go ahead.
Yes, I just wanted to know what can we do, or do we need to encourage all different kinds of face masks that is used by people that are not infected? They create a feeling of panic.
I think as much isolation as possible should be preferred without having a fear of panic, because the basic principle in this disease is if there's a source and there's a susceptible host. If we keep them separate, we can stop the disease. So as long as source is reaching to the host or host is coming towards the source, we will not be able to stop this disease. And if you will see the Chinese model at the peak, actually they went down to the complete lockdown, complete isolation, and that's how they were able to control. In the European countries and even the USA, we are late to go towards that complete isolation from the source, from the host. So that's why we are not able to control the disease yet. Only way it can be controlled, separate the host and the source. And I prefer if the people they use regular mask and stay away from each other, even they know each other, they are healthy, and that's the best practice. Without realizing, we should not be panicked about that. If somebody has a mask, yeah, that's for the protection. If we have that in mind, and that's the only way that we can control and should be encouraged. Thank you.
And then I see again a question, follow-up question from Dr. Afsar Munir. He's asking again, if a person gets infected with COVID-19 and gets recovered, is he immune to infection second time, or can he get it again?
There are a few cases. I think again we are learning about this disease as we move through this pandemic. In the China, I think the few cases have been reported acquired the disease again, but majority of the all over the world, we are not hearing a huge number that patient being infected again. So with that, I think my impression is that people they are developing immunity and they are not getting reinfected that much.
Very good. So I think I've gone through all the questions that I had. If our colleagues from Pakistan, if they want to make any comments, please either raise your hand or send me a message, and I can give you the mic and let you make any comments, especially if you have had any exposure to patients with COVID-19 or are going to get one. Please let me know. Otherwise, I think we can start wrapping it up. I want to let you know that the whole session was recorded. It was also posted on Facebook Live, and I think Facebook also keeps a recording of the session that was done live. But we will be posting this recording on a website, and we will send you the website. If you want to join the WhatsApp group to ask more questions until the next day that we come back, please send us a message and we can add you to that WhatsApp group to leave messages even afterwards that can be then addressed on the next webinar. We're hoping to do this session every day so that we can answer your questions and keep the discussion going. Thank you so much, Sajid bhai, for doing this. Let me invite Shahid bhai to do the closing comments. Shahid.
Ji, assalamu alaikum. Thank you, Danish, for moderating it. I think you you got to everybody, and thank you, Sajid. I think it was really wonderful. We went over time, but I think it's for good reason. We wanted to reach all the questions, particularly from Pakistan, but from here, as we learn from today's meeting, we will keep doing it better. I think we will have the introduction in the beginning. either verbally or on the chat. Also, there will be available introduction for the speaker, panelist, and others attendees, if we can find a way. But again, thank you very much, everybody. It's getting late here in Eastern Standard Time in USA, close to 12:30. So thank you all. Keep safe and keep doing the great job that you're doing.
Thank you, Sajid bhai. Thank you so much.
Thank you. Assalamu alaikum.
Thank you, everyone. Thanks for coming.